All right, you guys. So this is the part that I would like to go over because we got cut off on the last video. Um, so related to the what factors affecting the stroke volume. Earlier, we discussed what the stroke volume is, the amount of blood that is pumped from one ventricle with one beat. That is a stroke volume. Now, there are three factors that are important. One is called preload, contractility, and afterload. Now, as far as the preload goes, this, again, before the heart contracts, it needs to get loaded basically with blood. So before all those events, this is called pre, means before load, filling up the heart and so on. So depending on the actin and myosin position and how they can overlap with one another, what happens is, the heart can stretch to a certain degree. And if it's a stretch, thinking about a balloon that you're filling it up with water, as the water has certain weight, and certain amount, what it's going to do is going to cause your balloon to expand a little by little by little. All right, so it's allowing it to fill up more. So when you squeeze your balloon, let's say with your fingers, you're squeezing it, the water is going to come out of the balloon. This, instead of a balloon, could be a water bottle as well. All right. So well, the water bottle doesn't stretch. So the balloon would be a better example, but you're holding on top. So it's holding the water, or you're putting it underneath the faucet and it's expanding, right? And then when you're squeezing it, normally what happens? A lot is going to come out because it got filled with more water. So let's analyze this in terms of the heart so you understand what I'm trying to tell you. All right. So if this is the heart right over here, and let's just analyze one of the ventricle, the other would be the same. So if you remember, this would be the pulmonary uh, trunk, and then this is the AV valve. We are looking at the right side. The right side dealt with, oxygen poor blood. All right. So um, from the vena cava, the blood is returning to the heart. All right. This is sometimes is known as venous return. Okay. So think about it. The amount of blood, so the blood we mentioned from the atrium is going to go and fill up the ventricle, and then ventricle is going to contract and then cause this to go up, the 2A and the 2B isovolumetric contraction followed by isovolumetric, ventricular ejection, and then you open up the SL valve, and this goes to the lungs for oxygenation. On the other side is the same thing. This right side getting filled with similar amount of blood than the left side. So it's the same idea, except that from the pulmonary veins they go into the left side. It's oxygenated blood instead of the deoxygenated blood. All right. So now, if for whatever reason venous return is higher amount, think about when you're putting your balloon on faucet. Here's your faucet right over here. You're filling up your balloon right over here. All right. And the water is going to go in. As the water goes in, the balloon is going to stretch. All right. And then what happens? Now you could fill it up with more water, right? So as the water is getting filled up more and more and more, if you normally contract the balloon, that's what I'm trying to tell you. If you normally, like you put your hands and you're contracting it, because of the time that it was filled more is going to come out, right? And the amount of this coming out is similar to the stroke volume, all right? With one beat, what is the amount of volume that is coming out? Remember, end diastolic volume minus end systolic volume, the difference between them basically determines the stroke volume. And the diastole right now is relaxing, the heart is relaxing, is getting filled with blood. In systolic, when the heart is contracting and what amount of volume of the blood you end up with, the difference is what amount came out. So if venous return is higher, that means they are returning back more. All right. So instead of this much, now is filling up this much. So when they are contracting, what happens? More is going to come out. So the stroke volume is going to be higher in this case. All right. So at what type of event the venous return is going to be higher? When you have more blood is returning. All right. So again, one of the examples could be exercise because your blood vessels are surrounded by the muscles. So when the muscles are contracting, that pushing, that pushing the blood to return more. And also your heart is working harder too. But we're going to go ahead and take a look at that shortly. Okay, so if you remember, I gave you guys the equation last time, and we mentioned cardiac output. Cardiac output is equals heart rate multiplied by a stroke volume. So during the exercise, for example, heart rate we know is going up. We know the stimulatory effect, and the heart rate is going to go up because you needed more delivering of oxygen to the tissues, but also stroke volume in this case going up. All right. And because there's a higher venous return when you're exercising, your muscles on the sides of blood vessels are contracting, allowing more return of the blood. At least one of them is a reason, could be others, but heart rate is up, stroke volume is up, cardiac output is going to go up now. It makes sense because again, when you're exercising, you want more from your heart. Cardiac output. What is the output? The amount of blood that is coming out, all right, per minute, because that's what heart rate is. The rate of the heart per minute multiplied by the stroke volume give you the cardiac output. So yes, during the preload, the heart can stretch a little bit. You could see it on in here, preload, and you could see they are stretching right there, all right? And that allows more filling up the heart, obviously, okay? So now, if we go ahead and take a look at another scenario now, so help us understand the material by looking at few other scenarios. And again, learn the concept. So if I give you a different scenario, you can function. What if a person is, losing blood? So some of the blood is losing. Maybe the person got stabbed. Maybe the person got shot. All right. What happens to the venous return? Is the same amount of blood is going to come in and filling up the heart? And if so, why? And if not, why? And what do you think or your prediction is to the stroke volume? So first question you need to answer. What do you think is going to happen is it more blood is going to come in or less blood is going to come in? Because remember, you'll have blood loss right here, blood loss. All right. If you are losing your blood, maybe you donated the blood, whatever, there is less venous return is going to be low. So are they going to stretch the heart more? Think about, the water. You have very little water is coming in now. Is your balloon is going to stretch? No. Your balloon, if it's coming in, is just going to be having a little bit in it. That's it. Now, when you're contracting, less is going to come out, right? Same thing in here. when the heart is contracting, let's say normally, you don't have that much information about it. So what's going to happen is less stroke volume is going to go down, right? Now, heart rate wants to compensate for that because again, the demand for the tissues, cardiac output, is going to be the same. Your kidneys wants the same amount of blood, your heart wants the same amount, your brain wants the same amount of the heart, and so on. So if we are thinking about compensation, the compensation, the heart rate has to go up so that you could uh, monitor or at least help out the cardio output to hopefully bring that to the normal level until you get medical help, right? So that's what is happening. Now, to what factor is it going to be? Cardiac output will be the same, or would it be lower, or would it be higher? Definitely it's not going to be higher. Why would it be higher? I mean, you're losing blood. I mean, how much heart can work? You know, the stroke volume is going to be very little. Now, it depends on the severity. If very little is getting filled, blood is getting coming very little to the heart. Obviously, that's going to be tremendous impact on the stroke volume because not much is going to come out. Right? However, the heart rate trying to compensate by beating more and uh, and the rate is going to be higher so that you could compensate. But most of the time, it's probably going to be lower. Okay, but increasing the heart rate, you're trying to adjust. So it really depends. All right. Notice that when you are donating your blood, all of a sudden you're getting up. You might have gotten dizzy, if you recall last time you donated blood. All right. Why? Because there is not enough blood in there, not enough blood in there. The pressure is going to be lower now. If the pressure is going to be lower, this causing the heart not sending enough blood to the brain. And that's why you're feeling like you want to faint and so on. And you need to sit back down and things in that nature. So again, that tells you that the cardiac output is lower now. All right. But if somebody's taking your heart rate, if you are at that time, probably your heart rate is going to be slightly higher than normal because it's trying to compensate. So if we're looking at the compensation method, yes, you'll try to always do the negative feedback, and that's what you're trying to do. You wanted to optimize the cardiac output as a result of that. Okay, so now that you understand this, let's go ahead and take a look at a few other scenarios. Like, what do you think is going to happen during the sympathetic activity? During sympathetic activity, what happens to the heart rate? Do we know? Yes, of course we do. When you're scared, when you see the bear, for example, in your camping area, when you have an emergency, your heart rate is going to go up. We already talked about the effect of neuroepinephrine and the transmitters and having the different receptors, and that's why the heart is contracting more. All right. And then what about the stroke volume? Do you think the stroke volume is going to be higher or lower? And what is the reason for it? Again, to answer that question, all right, a lot of times there's two factors involved. One, the venous return is going to be higher, all right? In other words, they're going to get more filling, all right? So that is one reason. The norepinephrine is a vasoconstrictor. So when you're vasoconstricting a lot of different areas and so on, you're trying to return the blood more by squeezing the blood vessels. The diameter goes down, the blood pressure is increasing, and more pressure. Again, think about that this one, you turn the faucet more, so more water is going to come in. So therefore, they're going to get filled up more. At least that's one reason for it. All right. So yes, this one is going up, and it makes sense for the cardiac output to be higher as well. Now, what about the during parasympathetic activity? Opposite. Heart rate is low, you're not involved in energy consuming activity, and the stroke volume is going to be low as well. All right. But this has something to do with also contractility. which is the second part. Contractility is the second part. So we go ahead and take a look at the second part. This has something to do with the force of contraction too. So in other words, how hard do you squeeze your balloon filled with water? If you squeeze it, let's say with two hands as much as you can, all the water is going to get out. Versus if you barely squeezing it, very little is going to come out within given time, of course. And that is pretty much referred to the contractility. All right. So let's a little bit elaborate on that part. Uh, so this Frank-Stalin law of the heart is basically the degree of the stretch I just talked to you about. Now, before we go to the contractility, here's the interesting concept now. All right. This one, I don't want you to mix it up with the sympathetic and parasympathetic. A lot of students have trouble understanding this concept. So I'm trying to go over it a little bit. A slow heartbeat, when the heart is very slow to beat, all right, exercises we already discussed, increases venous return to the heart. Why does the slow heartbeat is going to cause increasing stroke volume? Versus earlier, I told you that in the sympathetic activity, they were not, okay? Sympathetic activity, heartbeat is fast, stroke volume is high too. So again, understand this concept. A slow heartbeat. If you have your balloon and your faucet is pouring the water, for example, inside of your balloon, all right? A slow heartbeat, that means you're not squeezing it as fast enough. So the water is getting filled, let's say it's supposed to fill up halfway, but you're not putting your hands to squeeze it, all right, until maybe the water is all the way to the neck area. Now you're squeezing it. You'll have more time to get filled. Obviously, if it's now all the way to the neck area and you're squeezing it, more water is going to come out because they had more time to fill. Same thing in here, slow heartbeat, and more time to fill. So when normally the heart contracts, we're not saying the heart contracts, more or less or at a higher rate or not. We're just saying normal heart contraction. Right? The slow heartbeat causes the stroke volume to go higher because it have more time to get filled. Blood loss and extremely rapid heart rate. Now, the blood loss we already talked about. It lower the venous return, so stroke volume is decreasing. But why extreme rapid heartbeat? Again, don't mix it up with the sympathetic activity. We're going to get to the contractility shortly. Extremely rapid heart rate. What does that mean? That means if you have a balloon, all right, and your faucet is here, all right, and you're filling it up. As soon as maybe it's like a quarter in water is in, you're squeezing it. So what does that do? What amount is coming out is analogous to the stroke volume. Is it a lot is going to come out? No, because again, you let it flow, water goes in, before it gets even to the half point, boom, you're squeezing it. So you could see why the stroke volume is lowering. Blood loss, I already told you. They're not returning back to the heart to get filled. That's why, right? So both of these activity is going to decrease the heart rate. Now, a legitimate question is, then why is it that in the sympathetic activity, the instructor told you in sympathetic activity, you have a rapid heartbeat? And I just told you the stroke volume is going up as well, right? And then a slow heartbeat is kind of like a parasympathetic activity. It's supposed to increase the stroke volume, but I just told you during the parasympathetic activity, a stroke volume goes down. So how do we explain these two phenomena? Well, a slow heartbeat and extremely rapid heartbeat is not because of the sympathetic or parasympathetic, because you're not we have to consider other factors that are involved, and that is contractility. Let's go ahead and take a look at the contractility. Again, the force of contraction is important. These are known as contractility, all right? And the strength, the force, how strongly the myocardium of the ventricles contract is a big deal. All right, so increasing contractility. These are the few factors. Increasing sympathetic stimulus. All right, so when the sympathetic activity kicks in, apparently, there's going to be higher contraction. And the explanation happened to lie on this slide right over here. Here is the neuroepinephrine, or NE. We understood that they release by the sympathetic post-ganglionic fibers, and it could affect the organs in different way. And in chapter 14, ANS, autonomic nervous system, we learned that this could cause the muscle to contract more, and the heart rate is going to go up. It's a simple G-link protein. So it binds to the receptor, and then it activates the G protein that activates the enzyme or adenylate cyclase, and adenylate cyclase break down the ATP to cyclic AMP. Earlier in the nerves, we mentioned that the cyclic AMP, it's basically a second messenger. There are different mechanisms for it, but it could activate another enzyme known as protein kinase. And the proteinate kinase can actually open up calcium channels, and more calcium from outside can get in. Now, this is the myocardium cell of the heart. So this is the contractile cells. If you recall, the contractile cells that was linked to the autorhythmic cells and so on. So now you have a lot of calcium inside of the sarcoplasm. All right. When these channels get in phosphorylation, or basically just know that they are opening up. Now, this in turn also protein kinase can cause the calcium to go inside of the sarcoplasmic reticulum. All right. And this a little bit later on is going to cause the removal and relaxation. But at this point in time, again, we discussed that the depolarization could actually release the calcium. And whenever you have the calcium present, whether from here or here, all right, this is going to bind to troponin, move the tropomyosin, and then finally you have higher cardiac muscle cells, right? So again, don't worry about different type of kinase, A, B, and C. They're just different proteins. They have different jobs. I'm not gonna ask you a particular one what it does. Just know that the cyclic AMP indirectly can open up a channel for calcium. Calcium can come in. Later on, this other ones can help to put it back in, but the presence of the calcium in the sarcoplasm, these are intracellular calcium, and that is important for binding of the troponin, and could cause the actin and myosin cross bridge formation, and obviously more contraction force. So going back to the effect of sympathetic activity, which that's what it is, and effect of contractility earlier that we mentioned, all right, this is the reason why increased sympathetic activity could cause the contractility to go higher. When the contractility goes higher, stroke volume is going to be higher. So earlier, when I told you, and when you are comparing it to the very rapid heart rates, as we discussed it earlier, all right, right over here, extremely rapid heart rate decreases the stroke volume. This does not apply for sympathetic activity, right? This does not apply for sympathetic activity, right? Because in sympathetic activity, we're dealing and increasing the stroke volume because of the force of contraction, right? Yes, the water is going to be halfway, but when the force of contraction is higher, then it causes more blood to come out. How much more, and what it is going to be comparable if you allow the heart to fill up more fast? It really depends. Really depends. All right, we've got to have the numbers to calculate to figure out which is happening and therefore what would be the outcome. Same thing goes with a slow heartbeat, and that is different than the parasympathetic activity. During parasympathetic, you have a slow heartbeat as well. Yes, you might say, well, now they have more time to feel, but the degree of the force of contraction is lesser. So that is, again, what are we talking about? What is the force of contraction versus how long is a slow heartbeat? A slow heartbeat could be so long that it's getting completely filled with blood. If that's the case, yes, the stroke volume would definitely go and outweigh and increase more than low contraction or contractility. Anyways, let's go ahead and take a look at other factors that can affect the contractility. Certain hormone, again, the presence of calcium in some drugs can cause increasing contractility. People sometimes, overdose because they're taking certain drugs or whatever. Some of them is because, the heart is contracting so much that it doesn't have enough time to get filled with blood. So obviously is going to lower the stroke volume at this case. And as a result of that, there's not going to be enough availability of oxygen to the heart. The heart complication can occur and so on. Similarly, factors that decreasing the contractility is also could be involved. One is acidosis. All right. When we have acidosis, we're messing up with the pH. And we mentioned the pH is important factors of uh, activation of certain enzyme. All right. Certain enzymes that is working under acidic condition, they don't work. All right. So you might ask me, what enzymes are there? Well, we can go ahead and take a look at here. Here is one enzyme, adenylate cyclase. Here's another enzyme, protein kinase. Remember, enzyme end with the ASE. And there are other ones as well. All right. So if acidosis interfere with the normal three-dimensional structure of the protein, they're not going to do their job. So what does that mean? You have less cyclic AMP. What does that mean? You have less opening of the calcium channel. What does that mean? You have less calcium coming in. What does that mean? That means less calcium coming in here too. What does that mean? Less calcium binding to troponin, and therefore there is a less contraction, and then that's what it means. It means that stroke volume is lower at this point in time. Again, try to understand everything I tell you rather than memorizing. Oh, calcium low. I'm going to memorize that contractility is going to be low. But without even thinking about anything that we just discussed, that's not going to be any help to you. It's not going to affect, it's not going to help you understand the material. All right. There are reasons for things. There are reasons for everything that we see. If you spend a little bit of time, 10, 15 minutes, brainstorming or discussing it with one another and analyzing what is happening, it's a lot easier to thinking critically and understanding the material. And if I tweak the problem and so on, you still can function because you understand the concept. All right. But if you remember, oh, calcium up, so stroke volume is up. Calcium down, stroke volume. It's just memorization of when one goes up, the other one goes up. Whenever it goes down, it goes another. What you didn't even think about. Any of these factors that we discuss is not going to be helpful to you. That's my recommendation. Understand what we're talking about. All right. So let's go ahead and take a look at increase extracellular potassium. Well, if this is the myocardium, and normally you have, due to the sodium potassium pump, you have higher potassium here and you have lower potassium here. And we mentioned during the repolarization state, this potassium is going to open and then, excess potassium is going to leave because they're voltage gated sensitive. And therefore you reach the repolarization state. But in this case, increase extracellular potassium. So what that means now, you're increasing this part, right? Well, when this channel is sensitive to the voltage changes, because the first, if you recall, this sodium channel, maybe I should draw it with a different color. Remember, fast sodium channel was open, and boom, sodium was in, and boom, you got like, from negative 90 millivolts all the way to positive, I don't know, around 30 or so. Uh, but what is happening? That's depolarization. This is going to cause the nearby channel to open. Once the channel open, do you think potassium wants to go up outside now? Look, you just increased the extracellular potassium. They don't want to go up. In fact, more potassium is going to come in. If more potassium is going to come in, all right, in this case, what's going to happen? Repolarization is not taking place. When repolarization doesn't take place, is action potential completed? No. In order for the muscle to contract the normal way, you need depolarization and also followed by repolarization. You don't want depolarization and more depolarization. It's kind of like your muscle contract and then stops because it's not repolarized in order to contract again. This disruption of action potential is going to cause disruption of normal cycle of the heart and obviously normal action potential that is supposed to be completed so they could again respond to the near next action potential is going to be halted, is going to be affected, and as a result of that, yes, low contraction. All right. Next up, we got calcium channel blockers. Again, if the calcium for whatever reason is blocked, now you might say which channel? Doesn't matter. You didn't specify. If the calcium channel blocks right here, or it blocks right here, will have similar effect. You have low calcium availability and now low cardiac force. So you could see why the contractility is affected. All right. Next up, we got, that's it. So those are the things that you needed to know regarding the contractility. So we discussed the preload, what amount of blood is coming in and filling up the heart before it contracts. We discussed the force of contraction, contractility. The next one happened to be, by the way, this one we may wanted to also talk about the parasympathetic activity. Parasympathetic activity, they reduce the contractility as well. All right. This one we already have the sympathetic activity, so we don't need to do that. All right. The increase in parasympathetic activity will lower contractility. All right. These are all the factors that can decrease the contractility. These are all the factors that increase the contractility. More force versus less force. Okay, so we are done with that part. We are left with the last part, which is the afterload. And again, think about when you are actually contracting the muscles, all right? And you know, the blood is leaving, right? So the afterload can be tricky, and I'm going to try to help you understand this part, and we can go and talk about it. Afterload is not a major factor that can affect the stroke volume. It affects the stroke volume on the people that have high blood pressure most of the time and people that the blood vessels near the heart is blocked. All right. Those are the two major factors that it can affect the stroke volume. In order to dissect this and understand the afterload part, let's go ahead and take a look at the next scenario. Let's find the room. All right. So here we got the heart. Here's the aorta. This time I'm just going to show you the left side, as you know. And this was the AV valve that is closed during the contraction. All right. So the contraction, normally the blood ejection, remember the ventricular ejection is taking place. And now you're ejecting this blood vessel. All right. The blood out of the SL valve is opening. And normally the blood pressure is 120 over 80, right? Your blood pressure when you take it is 120 over 80. 120 when the heart is contracting, pressure is higher. When the heart is relaxing, 80 is lower, all right? So again, when the heart is relaxing during the isovolumetric contraction, what happens? There is a backflow is occurring. Why is the backflow is occurring? Because the pressure in here is high. As the heart relaxes, the pressure is going to be lower in here. So the pressure always goes from higher to lower. So the blood is going to come back, right? It's going to come back, but this causing this valve to close. All right, so that's where we heard the second sound, the dub sound. So this valve is closed. No more is going to come in. Now, on the second beat, that was the first beat. On the second beat, let me go ahead and erase this again. On the second beat, what happens? They contract again. And same thing. Now it needs to overcome the back pressure that was exerted in here, which is normal. I mean, yes, there is a little bit of force, but the force of contraction of the heart is greater than this resistance factor going backwards. So the stroke volume is based on that, based on this force that is exerting, what amount is coming out. You know, yes, this force is coming out, you know, is resisting, but the stroke volume force is a lot higher. So overall, it still is going to go that way, but it's a slowing down. Now, if your pressure, instead of 120 over 80, let's say is 160 over, let's say 90, the pressure is going to be a lot higher. So this force, I'm going to use a different color for this force now, coming back is going to be higher. But a stroke volume is similar again on the second beat. So now it has to overcome this force that is back pressure, right? So no longer you're going to have the same force. There's less is going to come out because it still is going to go because you're overcoming this. All right. So this force that I'm showing you by the red arrow is greater than the black arrow, but is not as greater as a normal individual. Because why? The back pressure is now higher. So what amount of blood coming out of the heart? It's a stroke volume. So this less is going to come out. All right. So that's the reason why. Okay. So in a way, it's affecting the people with higher blood pressure. Now, another thing that help you understand the afterload, because this is after you load with the blood and then after. Another thing that can help you understand this concept is people would have arteriosclerosis, for example. This, if you didn't know, is a person with, here again, here's the aorta, all right? People with the heart condition, sometimes they have arteriosclerosis. It's of lipid deposits, for example, you know, cholesterol, things in that nature and so on. Now take a look. If normally the heart is contract and filled up with normal amount of blood, let's say, I don't know, 70 mil, for instance, all right, and then is going up, this part right over here that is plaques filling up is affecting what amount is going to come out, all right? Is the same amount is going to come out? No, it's going to have lower amount. Similarly, if you go ahead and take a look at the balloon, all right, now fill it up with half water and then squeeze it normally, because again, we're not looking at contractility. If I wanted to demonstrate higher contractility, then this force has to be a lot greater. But let's just say that we already done with the contractility and it's contracting normally. You're just putting your hands on the walls of the balloon and you slightly squeezing it. Now what is happening? all right? Is it a lot is going to come out or less is going to come out? Well, it's the same. This is normal. Certain amount of thing is going to come out. Let's say, 60 milliliter. But what if, I don't know, inside of these walls of the head area or the neck area, I don't know, maybe you put like, something to obscure it. You put a gum inside, for example, that is attached to the walls. Now you're doing the same force. Is it going to have the same amount come out or less? Remember, the amount of water coming out of the balloon is very similar to the stroke volume. Obviously, there is less is going to come out. So because, they are narrower, all right? So less is going to come out. This obviously is going to lower the stroke volume. And these are referred to the afterload. So when you hear this, oh, preload, contractility, afterload, let's just memorize it. Hopefully we can spot it in the exam and that's it. No, there is a story in each one. I told you every single one, I give you different examples to help you understand this better. All right. So as a practice, you could go ahead and take a look at this slide now. And this slide is telling you the same thing. Here's the cardiac output. Here's the heart rate. Here's the stroke volume. So again, go through it yourself. Think about, oh, what will happen if I have a high blood pressure, for example? What do you think is going to happen to the sympathetic activity, to the heart rate, to the venous return, all that stuff? What if I have a hemorrhage? What if I have excessive sweating? What if my temperature rises? What if I have an emotional trauma? A lot of these have something to do with what we discussed. Hemorrhage has something to do with the blood loss that we discussed. Excessive sweating, again, lowers the venous return because now you have less volume, all right? Trauma, emotional trauma, sympathetic activity, right? So again, what you need to do, track this, it tells you one is inhibit, the other one is increase, track it down, think about what it does in terms of venous return, think about what it does in terms of contractility, think about what it does in terms of the afterload, preload. Most of these are actually preload and contractility, all right? And go from there, all right? Give yourself some ideas. So cardiac output equals heart rate multiplied by stroke volume. Right? Ask yourself, what if this happens? What if happens whatever is happening to heart rate? What happens in the stroke volume? What happens to the cardiac output? Is compensation involved? Yes or no? If it is, then you're trying to do the opposite, all right? To help you adjust the cardiac output. That's what you're trying to do, right? So I think that would be a great practice for you to understand the concept, and you could go from there. Now, let's go back to the heart rate. There are a few other things that affecting the heart rate. One, we mentioned the epinephrine, obviously, either from the sympathetic activity or from the adrenal medulla. Also, people that are stressed out, their adrenal gland overactive, producing a lot of epinephrine, and epinephrine can increase the contractility and the heart rate. Thyroxine also increases the heart rate, and again, it enhances the effect of epinephrine and norepinephrine. These are the two chemicals that can affect the heart in terms of the increasing the rate. That means you're squeezing a lot quicker. Right? Intra and extracellular ions concentration, specifically calcium and potassium. All right, it must be maintained again for the normal heart function. If you play around with it too much or too little, that's going to affect the normal process of action potential, and therefore it will affect the heart rate. Generally speaking, if action potential is less likely to happen, then there will be a lower heart rate. If action potential more likely to happen, there will be an increase in heart rate. We already talked about the calcium, for example, and so on. Okay. Not only contractility increases, but also the rate. Same thing with the potassium. When you have a lot of potassium outside, then the repolarization doesn't stop. And again, what happens is this is going to cause the heart rate to go down tremendously. Lethal injection is, by the way, a lot of potassium in it. I think I mentioned this in the neurophysiology discussion, but it's the same concept. People that are death row and they get injection shot, lethal injection shot, the heart stops right away, right? Why? The rate is lowering right there. That's why it's stopping. You're interrupting the normal process of action potential. Vaporization doesn't occur. Right there, everything stops. Quickly, the heart is going to stop. Okay? So, give you a little bit of idea. Uh, Next up, there are other factors that can affect the heart rate: age, gender, exercise, body temperature. And you could look those up if you like, but generally speaking, again, heart rates of the person that is older might be different, might be a lot higher than the person that is younger. Male, specifically, they have a higher heart rate than the female. Okay, exercise, you already know. Body temperature, you already know. You know, when you have a fever, they take your temperature, all right, and they take your pulse to see if it's affecting your heart or not. All right, higher temperature will affect the heart rate, will increase it. All right, and that's what they're trying to take a look at. So you have tachycardia. This is abnormally fast rate, more than 100 beats per minute. If it continues, it could lead to fibrillation. All right, the heart is going to stop because it's exhausting. Just like you get a muscle cramps, and all of a sudden, your muscle is tired. You have to replenish it. Well, but the heart stops. I mean, you're not pumping any oxygen, so you could get a stroke. You could get a heart attack. This is very, very dangerous to have a tachycardia. Again, certain drug could cause tachycardia. The heart rate is going so fast. All right, people that overdose, people that eat or consume mixed medications. These are all you've seen a lot of celebrities actually passed away or died because of this reason. Bradycardia, all right, this is a slow heart rate, then 60 beats per minute. Now we're not talking about the endurance trained individual, because again, on those individuals, the heart uh, has a lot of myocardium. So this is an interesting concept, by the way. Cardiac output equals to heart rate multiplied by stroke volume. Contractility causing, affecting the stroke volume. Higher contractility, higher stroke volume. Well, people that continuously exercise, their myocardium, this is the myocardium, contractile cells, is really thick. So if it's thick, they have more force of contraction. So normally when they are pumping, the heart is beating, they can pump a lot of blood out, okay? Because the force of contraction is a lot higher. That causes the stroke volume to be high. That causes the heart rate to be low so that you can adjust or no change in the cardiac output, all right? In fact, that's exactly what we did on the first experiment. You took your pulse, and then we had two groups of exercise group and non-exercise group. And again, we expected the exercise group would have a lower heart rate for a reason. And that's the reason for it, because their stroke volume is much, much higher. The contractility is a lot higher. So when the heart is contracting, a lot of blood is going to pump to the tissue. The heart doesn't need to beat so much. All right. So again, a lot of times cardiologists thinking heart as a car. When you abuse your car, putting a lot of mileage on it, take heavy load with it back and forth, going all over the place with it, not taking care of it, not tune up, or doing any oil change and things like that, your car is going to break down. But it's in the same way. When you exercise, yes, your heart rate is going up during the exercise, but for the most part, once it gets conditioned and you develop this thick myocardium, now you're good to go. In other words, now you don't need to exercise. You don't need to, your heart doesn't need to contract at the higher rates. So you're actually putting less mileage on it. On the person that is sedentary or non-exercise group, the stroke volume is lower because they have myocardium and the rate of contraction is less. So the stroke volume is going to be less than normal. Now the heart rate is going to compensate by going up. So if you took your pulse in a continuous basis and the pulse showing you the heart rate is always up, that tells you that your stroke volume is probably low due to the factors I just told you. You need to exercise. And that, yes, the heart is going to adjust the cardiac output again. But your heart is paying the price. You're putting a lot of mileage on your heart. And that's the problem with it, right? So bradycardia is heart rate is slower than 60, but this is not really, we're not really talking about endurance training or the athletes. In general, when the heart rate is slow, all right, this unfortunately is going to have an effect in here. Heart rate is low. Yes, the contractility is going to be hard to adjust it, but when the heart rate is way, way too low, this cardiac output might be low as well. And that is going to cause inadequate blood circulation. Now you don't have as much oxygen for your tissues, including, your important organs, obviously, right? So everything is about homeostatic balance. All right, on the next slide, you could just read it. If the cardiac output is continuously low in the blood, again, your tissue is still have the same demands. It's kind of like what's happening now. If you're out of work, your payment's still in place, all right? You still need to pay for your rent, you pay for your car and things like that, but you're out of job. The demand is going to be there. Your payment is going to be there, right? This is the trouble that a lot of people are facing right now, right? So this could cause by, this is congestive heart failure, coronary atherosclerosis that we discussed. Coronary arteries are really important to feeding the heart, and you learned it in anatomy. You had major blood vessels going into the heart on either side, for instance, and so on. And if this one is blocked, then you have a heart attack, basically. Persistent high blood pressure. Your blood pressure is always high for a reason. Again, maybe because of clogging, or there are plaques, or lipid deposit. There are multiple myocardium infarcts. This is again mini strokes. Uh, Dilated cardio myopathy, So again, this just tells you that if the heart is not functioning properly, and it's going to affect the cardiac output. That's what it's trying to tell you. Both factors, heart rate and the stroke volume, was important to the cardiac output, all right, to achieve homeostasis. All right, I hope you enjoyed the lecture. You learned something. Again, go back and review it as much as you can to grasp the idea. Until next lecture, be safe and sound.